Right, so as I say, good afternoon, everybody. Thank you for joining us for this webinar today, Macula Services, Understanding Challenges and Opportunities Together. My name is Helen Court and I work with Jackie Dougal and with Janet Pooley in the National Eye Care Workstream. And we are absolutely delighted to be able today to bring you this webinar jointly in collaboration with Eye Health Scotland. So we have got a very full and exciting agenda today. So you'll notice, first of all, if I can just move my screen. Here we go. Oops, sorry. There we go. So the agenda today, as you can see, we've got some excellent speakers and we're hoping to keep it very rapid and quite quick, because what we would love is to have a really good question and answer session at the end. So we had over 130 people from across all the boards who've registered today. So there's a real opportunity to get a wealth of questions and different perspectives. Before we start, though, what I just wanted to do was give everybody just a little bit of housekeeping, just to keep us all sort of all right and on track today. So first of all, you may have not been on a Teams webinar before and just a Teams meeting. It's very similar, but what you will notice today is that as a delegate, you actually can't put your video on and you are muted. That's really just for a technical reason, to ensure that we don't get too many technical issues. But we are very keen to have lots of questions. So today, if you do have a question, if I could just turn your attention to the chat box on your screen, and at any point during the talks, any questions that you have, just pop them in there. And then that last 15 minutes, I will field all of those questions, or as many as is possible, to our speakers today. Also, as speakers, sometimes it can be a little bit difficult when you can't see people's faces. You've no idea if people are smiling or if they are looking grumpy. So it's a really good opportunity. If you have the functionality on your platform, you can use the little emojis, the reactions, whether it be a thumbs up or a clap. It's just always nice to get a sense, a bit of reaction from people listening. So please do make use of that. I should also say that the session today is being recorded. So we've had a number of people who've been very keen to hear the webinar, but haven't been able to be part of it today. So that will allow them to see it. But also everybody today, once the webinar has been edited, will be sent a copy. Probably it will be the beginning of next week, so you can see it again. If you have any technical problems today, the last thing to say is generally the best thing to do is to just leave the webinar using the little red telephone symbol, join again. If you're still having problems, then do feel free to write that in the chat box and I will do my best to try and help sort that out. Well, without further ado, let me pass over now to Caroline. I'm just going to put my Teams, there we go, into presentation mode. So Caroline Stiles is consultant ophthalmologist in NHS 5, but Caroline is also the CMO National Advisor in Scotland. So it's with great delight to welcome Caroline. So Caroline, if I can ask you to unmute, and I can move the slides for you as required.
Thanks very much, Helen. Can I just check you can hear me?
I can hear you, and hopefully everyone else can.
Thank you for the opportunity to talk about the current challenges in Macula Services. I'll start with the challenges, and then my colleagues are going to tell you about some of the opportunities that they've experienced in Macula Services. So thank you for the introduction, and thanks, Helen, for organising this. Could I have the next slide, please? So why do we have challenges? Well, it's because we've been very successful in developing excellent sight-saving treatments. Sorry, I just can't see my slides with that coming up. So these treatments are intravitreal treatments for wet macular degeneration, central retinal vein occlusion, branch retinal vein occlusion, and my favourite, which is diabetic macular edema. So 20 years ago, the natural history of AMD was acute central visual disturbance and then unremitting vision loss. So we would see these patients once for the diagnosis, maybe twice to ensure that there was some support, but that's it. And for diabetic macular edema, we did laser treatment, and we probably do that 3 times in someone's lifetime. So that was 3 appointments. If you look at that graph on the right there, that's the kind of landmark trial for the for using intravitreal treatments for diabetic macular edema. And you can see the 2 top lines in the graph show you that you get much better outcomes using intravitreal treatment than you do just using laser. You know, for the first time, patients with this condition can get vision improved, and it's the same for vein occlusion, and these treatments prevent vision loss in wet AMD. But if you look at those lines, at all those dots, and all those dots represent an injection or an appointment. So this is not just the 3 appointments or the 2 appointments before, it's very many appointments per year, and it's a long-term treatment. This treatment's not a cure. So for ophthalmology departments, this has become a really large part of what we do over the last 20 years. It can be very successful treatment, but it does require a full process. So next slide, please. So if we just look at wet AMD, we will see that this is part of the pathway. This is only half of the page from getting it right first time. There's a pathway for the community, and then there's a long pathway for the hospital as well. And this is what we need to do. You can't just supply the drug. You need a lot of people involved. Another really important part of the pathway is that it's timely. So if I just have the next slide, please, and I'll show you some of the guidelines that we need to achieve in the hospital. So we should start treatment in wet AMD within 14 days of detection. That's how you get the best outcome from this. And the next one, please. And then this is, of course, not a one-off treatment, but all of these start with at least 3 loading doses, each a month apart. So we should complete that course within 10 weeks. And then there's also a primary care time frame as well. Next slide, please. And that if you suspect wet AMD, it's suggested that there is an urgent referral within 1 working day. So we all need to work towards those to achieve the best outcomes. Next slide, please. So in order to achieve those timely treatments, we need to all work together to get the right person in the right place at the right time. So this is just a little project we did in Fife to get the referral absolutely honed so that we have a one-stop service. So when people come in for their wet AMD appointment, they've got wet AMD. They know they'll most likely need intravitreal treatment. They're the right person in that clinic, and we don't waste the slot that could be provided to someone else. If we've got dry AMD or diabetic macular edema in that clinic, then we are creating delays for people with wet AMD. So we've worked out exactly what we need in the referral, the fundus images, where the OCT can be. And many people use your excellent referrals to just phone the patient and talk about intravitreal treatment and list them directly without needing to see them in the clinic. So that really helps us to reduce delays to that 14 days. Next slide, please. So our challenge that we're talking about today is really to avoid preventable blindness. You know, we can prevent people from going blind with these treatments, but it does require that we all work together. So we've got that rapid access referral form, and the optometrist can send us in all the right information so that that patient can be seen as soon as possible. And we also want them to be able to access their healthcare early, because the earlier you get this treatment, the better the results are. We in hospital then need to deliver the treatment in a timely way, and not just for that loading dose. People need many, many injections over the years, and we need to be able to deliver each of those injections on time. That's quite a challenge. If we look at the results from the trials, real world is often very different. We have patients who have other morbidities. Most of the people who are having AMD treatment are over 80. They need a carer to bring them or relative, and it is difficult to access always come to your clinic on time. But you still need to try and avoid the preventable blindness. And then if we look at that map, that is the map of Scotland, obviously. It's the deprivation map, as well as showing us that although most of the population perhaps lives in an urban area, there are also very many rural populations. And everything we do in our pathway must allow people in urban and rural populations to access the treatment that they need in a timely way. And also just not to forget that we mustn't create pathways or address these challenges and in the process create inequalities. So those are the challenges. I'll now hand over to my colleagues to talk about some of the ways in which they've addressed these challenges. Thank you.
Thank you so much, Caroline. That was excellent, and just a good way to kind of summarise and get some context as to where we are now at the moment nationally, and sort of the challenges. So, as Caroline just said, we're going to next have a think about some of the ways that potentially capacity can be increased, and I've invited two health boards, representatives from two health boards, who are going to give some indication of what they've been doing. So first of all, we're going to hear from Breda Donnelly, who's Senior Charge Nurse in NHS Grampian, who is part of an excellent injection service, and Breda's going to tell us more about that in a moment. And then I'm really pleased to welcome Ash Khan and Karen McCabe from NHS Lothian, who will be talking to some of the approaches they're thinking of taking and are taking at the moment as well, again, to meet these challenges. So I will pass over to Breda first, and let me remind you, please do feel free to put questions as they're speaking into the chat box. That would be great. Breda, I'll stop sharing my screen. Are you able to share yours? That's great, Breda. And then you'll just need to unmute, Breda. There we go. Super,
Hello,
Breda. I'll pass over to you.
Hello there. Hi, I'm from Aberdeen Royal Infirmary, and I'm here to represent our service here. So I'll just move on. So we deliver approximately 260 to 280 injections a week. It's a service that covers Aberdeen Royal Infirmary and also Elgin, Dr. Gray's in Elgin. I know Caroline mentioned age-related macular degeneration. We also, our injection service is fed in as retinal vein occlusion, macular edema, and proliferative diabetic retinopathy. The medical retina clinics within our service, they all feed into the intravitreal injection service. And quite rightly, Caroline said, and the referrals from the community optometrists are very, very important. In NHS Grampian, we have a highly evolved Grampian eye health network, and our referrals are the quality of our referrals are very, very important from that service. And also we also get referrals directly from the diabetic eye screening services. And I was relieved, Caroline, to talk about the right patient, the right clinic, and the right pathways, because I'm going to be saying that a lot. And it's very much getting the right patient right into that clinic. So we've actually found in Grampian a real cornerstone of our services, consultant of consensus, and a cohesive team working with those patient pathways. So our team is made up of specialist nurses, specialist optometrists working alongside the senior medical team. And then our injectors are nurse injectors, optometrist injectors. We also have registrars as well. And another very important thing is we have the right clinical staff making the right decisions. So what do we focus on in Grampian, and what is it we've actually learned over the years? Because I think, as Caroline said as well, we've been delivering the service since roughly 2007 time. So the focus has to be on delivering injections on time. The focus has to be providing capacity that matches a demand. So I actually feel that your activity, your kind of weekly activity, and some weeks can be very misleading, because that activity can be, I don't say, but it can be sometimes very reactive to things like weather. I'm actually going to mention the weather because we are up in Aberdeen and we get a lot of snow. So we have weeks where we have Christmas and New Year. We know these come around every year, but these are things that really, these are episodes in the year that come along, you know, for whatever it is, holidays, leave, maternity, that can really impact on that service delivery. So another very important thing that we focus on in Grampian is continued education and support for the community of optoms to improve those referrals, to hone those referrals, and these are delivered with regular community optom eye health network meetings, and our consultants and senior optoms attend those meetings. There's also teach and treat clinics, teaching here with referrals. So it's recognised as being a very important part of the continued education. So our medical retina team also have monthly meetings, and they're a very important forum for the senior team to actually discuss and review improvements, pathways, and assessment of what's actually working. Some recent examples of that have been the implementation of some of the newer anti-VEGFs available, i.e. 8 milligrams. Vabysmo, very, very important, and also planning for the biosimilar changes. So these very regular, very important medical retina meetings are also the way that the medical retina team ensure that these changes are implemented correctly. So some old slides, but some of my favorites. So demand has to meet a capacity, otherwise you end up looking like you're just, you know, it's your activity can be, as I say, it's not a misleading, but your activity can be really, you can be catching up the whole time. So that's why your demand and your activity and your capacity are so important. So we've actually evolved to have highly specific the clinics here. So we've highly specific face-to-face AMD clinics, face-to-face diabetic clinics, face-to-face retinal clinics, and by having such specific clinics, we can quickly identify if there are delays in certain clinics, and it can be because one of the clinician and maybe a specialist optom have been on leave. So we can really see very, very quickly that there's delays in that clinic. Okay. So yes, Caroline again mentioned the rapid access. I actually think that you call it up here in Grampian. We actually call our wet AMD referrals fast track, and these patients are seen within 2 weeks on a one-stop face-to-face AMD clinic, and they're actually injected on the day. One of our senior clinicians in Santiago, she came back from a conference a couple of months and said, right, we need to be meeting the 10-week loading phase for it's a target for patients, and we implemented that, and it's going very well. So again, there's always things we can improve on. So up here in Grampian, we tolerate no more than a 2-week delay of injections. That's our cutoff, and that's what we expect. So we respond to, and we have confidence we can respond to these pressures because we have confidence and belief in the pathways. I told you I was actually going to mention the weather. I'm going to mention the weather again. We had a week of snow in November. We had the Christmas week where we lost 2 full days of injections. New Year week the same, and then we had a couple more weeks of snow. They were potentially, you know, they were actually very, very impactful. We managed things very, very closely, and we were back on track without delays for injections by mid-February, and we only ever went out to a maximum of a 2-week delay. And I'm going to say then the school holidays, and we're facing into Easter leave. So this is all very real world recognizable pressures, I'm sure you can all relate to. So I would actually say that there is relentless micromanagement of every aspect of this service. Okay, and I make no apologies for that at all. And every appointment is valued and utilized. So it's a resource intense service. So the senior nursing team, myself and the senior staff nurses, we schedule and monitor the IVT leave, and that's the specialist nurse injectors, the optom injectors, and the registrars. And we work very hard on maximizing injection capacity on a week by week basis. We actually work. We start like 8 weeks in advance, and then we work backwards from there. We've a senior optometrist who manages the face to face capacity, again, trying to maintain consistent face to face capacity on a weekly basis. And we have an especially conscientious clinic coordinator who works very hard at making sure that we that all the appointments are used. So again, I'm going to say it's a real team effort. So here in Grampian, we have face-to-face clinics. So like I would say that roughly 1/3 of our IVT are actually delivered on face-to-face clinics, and that is patients being injected on at the same day. There's OCT injection clinics, and they can actually really target the treat and extend aspect of this disease. You know, hopefully getting patients out to increase intervals, maximizing capacity and minimizing the impact of extra appointments. Injection only, diabetic optos, highly evolved virtual clinics. So there's specific virtual clinics for AMD, RVO, DMO, diabetic retinopathy, medical retina. And again, the aim is to have the right patient in the right clinic on the right pathway. So whose responsibility is that? I would, like in my experience, that has to come from the senior medical team, creating robust pathways that actually that lead to consensus, cohesion, and an expectation within the team that are supposed to meet that. Right. So how did we arrive here? Because it's been a service that's evolved over many years. So One Stop started in NHS Boards in 2013, and what we did there was we committed to leaving our injection rooms empty on the day, and we were able therefore to inject all of our face to face patients on those clinics. We didn't really work with virtual OCT. And then 2014 it was nurse injectors. 2015 ILEA, the latest anti-VEGF, that allowed us to reduce demand on imaging. It also accelerated the treat and extend potential of this disease. So services up in Elgin then were re-established. Elgin, for anyone who doesn't know, Elgin is 90 miles from Aberdeen. So we redesigned a service that will be supervised or monitored from Aberdeen, but the intravitreal injections will be delivered in Elgin. We actually learned a lot from that, and we implemented some of those changes in Aberdeen. So what I also want to include in how you get here. So there's been a relentless increase of between 800 and 1,000 injections a year. So that's the challenge that actually faced. But we're also where we are now as well is because we've continued to use the latest anti-VEGF, and these latest anti-VEGF are increasing the intervals achievable between injections. Again, these have needed new pathways, and these pathways are essential for consistency of treatment to patients, which in turn supports the HPs. So a continued evolution of this service has only improved its resilience, and I would actually say that Vabysmo has been a significant tool in that. Again, new pathways, and the supervision and cohesion of the team all comes from the senior medical retinals team ability to agree on these pathways and have confidence in these pathways. So my next graph is here. So we've actually used Medisight and NHS Champion since 2010. Again, that has been really, really helpful. So this is a graph that I could have taken from 2010. And I would have just showed this inevitable rise, absolutely. If you want to notice years 2024 and 2025, the first year that we didn't see like an increase, and that was the Vabysmo effect. Undoubtedly, a novel pathway which increased the potential for the intervals between injections. So another very important aspect is you must be able to provide injection cover basically 52 weeks of the year. Okay, you know, if we're all NHS Champion employees in the hospital service, we've 8 weeks leave a year. It's a lot. So having our leave can have significant impact on a very time-sensitive service that can't tolerate delays. Okay, this can have a knock-on effect on the potential of these pathways, and because we're really trying to 60 weeks should actually mean 60 weeks, getting patients out to their maximum interval safely. And what you're doing is you're achieving the benefits of these new drugs. Okay, so leading a very complex team like this is very challenging. The leadership requires, you know, hard decision making and a commitment to excellence and a recognition that every aspect of this service is important, from admin to injection. And the fundamental foundations are delivering injections at the intervals that optimize treatment and in service capacity. So I'd ask you what's actually stopping you. Small changes can make a big difference, and like in our experience, the foundations of the service are robust pathways that deliver timely treatment, maximizing the capacity and the demand of your service, mindful of all the challenges within that service, and achieving these injections improves outcomes for patients in the sense of achievement for all staff. Thank you.
Breda, thank you so much. That's fantastic, and certainly just so much information and extremely encouraging. So thank you for spending that time preparing that and sharing with that. So please, if you've got any questions, do put those in the chat now that you might have for Breda. And if we can pass straight over with no further ado to Ash and Karen, I will allow them. Breda, if you can just stop sharing your screen, actually, that'd be great. There we go. Lovely. Ash, Karen, I'll pass over to you to talk about NHS Lothian.
Thanks, Helen. Thanks for the first two talks, Caroline and Breda. That's really set the background. We don't have any slides, fortunately, but we certainly have a story to say about the journey we've been on in Edinburgh. So as the first two talks have said, there's lots of areas to optimise in treatment which require intravitreal treatment. And we focus on one of the areas which is to do with delivering the actual treatment. If we go back to last year, we like many health boards were underwater. We're really struggling. Patients weren't achieving their injections on time. And so it was not uncommon for patients who were meant to get injections every month and they were receiving them every 2, sometimes every 3 months. And the reality when you're in that situation and you're completely at capacity and unable to give any other injections is you're not sure whether your treatment's working or whether your disease is resistant because you're just simply not giving the injections on time. And there was limited capacity with which we could actually increase our delivery of injections. Whenever we gave more injections, it had a huge cost implication to us because we had to factor in the cost of the drug. And so just doing one extra injection would cost thousands of pounds. And it's not uncommon to have patients phoning up, crying, feeling that they're losing vision simply because they weren't achieving their injections on time. So there were lots of possibilities raised, such as switching to Vabysmo, to using different drugs. But the reality was, if we can't get the injections given on time, we don't know where we're standing. We can't audit our results. We can't see if it's being effective or not. So they weren't addressing the clinicians' concerns. So what we did, we sensed an opportunity with the biosimilars that were coming out, in that we anticipated that there was going to be a huge cost saving in using them. But again, saving that money and not increasing capacity is only going to lead to worse outcomes, which means that we're not going to save patients' vision. And we're doing all this treatment to save patients' vision. So if we change to a more cost-effective drug, but then still don't deliver the injections on time, we've achieved nothing. And so we then had to say to our finance department, and we had very good people in our finance department who were on board with this, that if we want to allay clinician concerns, look at the issues that we've got and dealing with the actual problem, which is patients going blind. And we know from Caroline's talk that the natural history of patients with wet AMD is patients go blind. So if we want to allay those concerns or try to address them, then we need to utilize the funds that we would generate from the cost savings from the switch to biosimilars to reinvest in the service. And so we worked out that with the capacity that we've got, we could generate an extra 4,500 injections a year, which is a huge increase from what we're doing at the moment, if we were able to switch to biosimilars. And since, so if you go back and say last year, we were delivering injections maybe 2 to 3 monthly at best and struggling to get any injections given urgently. And in the space of a couple of months, without full recruitment and without the full complement of staff being added, we're now able to achieve injections given 4 or 5 weekly. So that's fantastic. It's not addressed everything, but it's managed to mean that we can roughly get patients treated in an appropriate timescale. But there's still lots of challenges in terms of doing the urgent injections, because I saw how Grampian can treat patients on the same day and how Fife can also do one-stop clinics. We're struggling with that and we can't do that at the moment, but that's something that we can certainly try to look at with the capacity that will generate through these injections. We also need to look at, we've got a bus which is having more and more patients added on at every stop, but every month we've got fewer and fewer people discharged. So whilst we've generated this capacity, we need to try and make sure that that's a sustainable thing for the long term, which includes, are we discharging patients appropriately? And that's involved engaging the realistic medicine team locally to make sure that we can look at, are we doing the best things for the patients within a reasonable expectation for the service? And also, can we see patients in a timely manner? So we might have increased all this injection capacity, but we're still struggling to see patients within that 2-week timescale that we set out, and some patients are waiting longer for that. So the goal is to address all of these issues, but hopefully with the increase in the injection capacity that we've generated, we can go some way to addressing them. I'll let Karen speak if she wants to.
Thanks, Ash. Yeah, so just on the back of when I started in ophthalmology in 2015, we were injecting around about 7,000 or delivering 7,000 injections per annum. We're now more than double that. So Brida's point about demand and capacity is absolutely key. So I think the challenges for me personally were twofold. It was around about making sure that patients were treated on time, but also, as many service managers on the call will understand, there's a financial pressure in the element as well. So as things have got tougher, as you know, year on year within the boards and financial recovery plans becoming even harder to achieve, we were certainly under the spotlight for quite some time in the amount of money that we were spending on anti-VEGFs. Any additional sessions that I was able to put on was when we got the odd sort of flurry of non-recurring funding, but that didn't resolve the problem. It just helped it for a month or two, and then we just went back to the same challenge. So when Ash and I were working alongside our finance colleagues who were integral to this process, we worked out that if we moved, I think it was approximately 70% of patients with AMD across to the biosimilar, we would save a significant amount of money. So we saw an opportunity there in that to be able to do this, we would need additional staffing. So we would need additional injectors and injection teams. And we also thought it'd be really helpful if we could fund a medical retina fellow to bring into the system. So we put that forward, and our finance colleagues costed that out, and that was accepted. So that was really good that we were able to switch to the biosimilar and also get additional staffing out of it. And in terms of the net savings for ophthalmology and NHS Lothian, it was 2.5 million this year. So we've actually wiped the floor with our financial recovery plan for the whole of the site, which we come under St John's in Livingston. So it's really been beneficial, first and foremost, to improving the service and the access for patients. It's taken pressure off a lot of the medical and clinical staff because they were seeing these patients face to face. We've seen our number of complaints reduce because every week I was averaging about 8 to 10 complaints from people who weren't having their injections on time. And the complaints were actually quite heartbreaking because they were just inquiring, they were just desperate to know, when their next injection would be, would this affect their chances of sustaining their vision? And these things are really difficult to answer. I think we all know the answer to that question about vision, but it's very difficult to put that back in a response letter. So across the board, I think it's had a really positive impact. As Ash said, we've still got some work to do. We're currently delivering some extra injections at the weekend just now until we recruit the additional staff. So interviews for the nurses are happening over the next month, and we'll be delivering an additional 7 injection sessions between the Eye Pavilion in Edinburgh, St John's Hospital in Livingston, and hopefully East Lothian Community Hospital, which we've got quite a large population both in East and West, so that will save them having to travel into Edinburgh and try and get their families to bring them in for their appointments. So hopefully a reduction in DNAs and CNAs as well, which has always been a bit of a challenge for us. So thank you.
Karen, Ash, thank you so much for sharing the journey actually that you've been on and are still on, but have given us context over the last number of months and actually years. So thank you. That's been really really helpful. So I'm going to just with no further ado just move on and introduce our final speaker before we go to the question session, and that is David Gilmore. David is consultant ophthalmologist in NHS Greater Glasgow and Clyde, but also the clinical lead for the EPR, and the EPR has the potential to really gather an awful lot of data on macular services that potentially can really make a difference then to how we deliver top quality service for our patients. So I'm going to pass over to you, David, and let you continue.
Thank you, Helen. So I'm going to cover sort of digital progress and the benefits of EPR, and really centre around what I've had my experience in Glasgow and Clyde. We'll talk a bit about the National Ophthalmology Database, the AMD data extract from OpenEyes, which is the platform that the National EPR is based on, and we'll look at some results of what it's done so far and then some future plans. So, and this is quite a personal story for me. I trained in Yorkshire, and every unit I worked in Yorkshire had a regular systematic audit of IVT services based around the electronic patient record, based around Merisoft. So I thought this was just normal for MR services to have this level of audit. And how wrong was I? I moved to Glasgow, and there's clearly no resource for that. We spent about 3 years developing an in-house MR EPR, which was rolled out across MR services and then discontinued in 2014. We then started around 2017-18, the national EPR project was born, and to cut a long story short, 7 years later, we've now got systematic audit of IVT services in Glasgow and Clyde. So it's taken half a career, but we've got there in the end. So I'll just talk about the AMD node extract from OpenEyes. So this is not actually just AMD, it's all IVT patients. So we've done one extract so far, and that was done in November 2024. And we've got a lot of data. We also pulled all the hospital appointment data from TrackCare. So as you can imagine, there's a huge amount you can do with this. So we can report on all IVT indications, AMD, DMO, RVO, and unlicensed indications. We can report on individual hospitals. We can do sub-analysis based around baseline visual acuity, specific IVT drugs. We can look at switch patients. The first audit, though, we did was based around the NOD's RCOP AMD audit. So NOD, for those of you who are maybe not aware, is the National Ophthalmology Database sponsored by the RCOP. They've been publishing cataract audit data since 2010, AMD data since 2023, and these are very well described data sets, very specifying mandatory, desirable, and optional data fields, very detailed methodology, and very clear service quality standards. There's some excellent documentation there, and you can use those to compare against your services. So this first audit report from GGC based on the extract was for treatment naive eyes with exudative AMD, looking at the 2022 and 2023 NHS year. This is all Glasgow hospitals, all anti-VEGF drugs, and essentially it's an exact replication of the 2025 NOD AMD report. So there had to be some additional work on top of just getting the extract from Open Eyes. We needed local Called Guardian approval, national approval. The analysis, all the analysis was carried out by a GGC data scientist, where you had to look at some missing data from the Open Eyes extract, the date of receipt of referral. We had to get from the Sky Store database. As I said, we got appointment data from TrackCare, and we had to add the profession of injector, which is not part of the Open Eyes extract. We also had to do some validation because a lot of patients had been labelled as having their first injection in Open Eyes when it actually wasn't their first injection. So we did some manual review to look at that. So this is the sort of number of eligible eyes that we had for each year. We've got 54 in 2022, which was just two centres in Glasgow, and then 2023 it was all the centres that were delivering AMD. So in terms of headline results, Caroline mentioned this is a national kind of standard completion of initial loading phase of ×3 injections within 10 weeks. And you can see the average for all RCO is 64.8%. We are way below where we should be for 2022 and 2023. And that's obviously way below the national acceptable standards. And what's interesting with the AMD NOD audit is that they publish all the data from all the centres, so you can compare your data against other centres. And that's where we were in 2022. NHS Grampian are in the top half, and NHS Tayside right at the top. So slides like this become very powerful, and especially when you're presenting to senior managers. And it's really what you need to make the case for more resource in a chronically under-resourced service. We're looking at the median VA outcomes, obviously important clinical outcome for clinicians after 12 months. 2022 we had comparable with the average for the RCO. 2023, when we had all centres, we went down to 0 as the median change. So again, with that in 2023, with all our centres, we're way below where we should be. I'll skip through this in the interest of time. So future plans for the reporting. We want to do some more work on the exudative AMD, looking at waiting times for clinics, look at outcomes by hospital site and for eyes with less than 35 letters. We want to compare drugs, IVT drugs, looking at safety, effectivity and value for money. Obviously important in the era of biosimilars. And we want to do the audit reports for the other IVT indications. And we want to repeat this process annually with data extracts on July the 1st, which would incorporate a full year of follow-up data. So this is just a wee bit of a last couple of slides on some sub-analysis we've been doing. I was interested to know how many eyes have got less than 35 letters at baseline, how many of these eyes got better vision in the fellow eye, and how many have evidence of subfoveal fibrosis. So there's actually a big chunk of patients have got poor vision when they're starting treatment in the cohort that I presented. Over 3/4 of these eyes had better vision in their fellow eye, and over half had subretinal subfoveal fibrosis. So in a chronically under-resourced service, we can start a conversation around, prioritising patients. Should we be prioritising these patients in the same way as patients with better vision, or patients with only good vision and only one eye? So what happens to these patients at 12 months? Well, most of the patients have stopped treatment. About a third of patients have carried on, but the majority of these still have got better vision in their fellow eye. So we can look at which hospitals are treating these patients, and we can start a conversation, as I said, around potentially freeing up capacity that we desperately need for patients maybe that are a higher priority. So these are the conversations we can have based on the data that we've got. So in terms of summary and future plans, the AMD NOD data extract from Open Eyes, the national EPR delivers high quality data for all IVT patients. All health boards with Open Eyes will be able to access this same level of analysis. And we've got some future plans for a national health economics tool to assess the cost effectiveness of IVT services. And there's a possibility to develop an outcome prediction tool and then integrate a decision support tool into the electronic patient record. And all this has just become possible since Glasgow and Clyde implemented the electronic patient record. So just that the final slide, just obviously a lot of people involved with this. There's a huge amount of work, and I think that's all I've got to say. I'm happy to take any questions.
David, thank you so much. That was fantastic. I just realised when you were speaking that just for anyone who isn't aware, maybe the majority are, that across all the health boards, and as David said, for the last few years, it started that we're rolling out a national electronic patient record. So even if your health board at the moment, you've not heard about it, it's called, the product's called Open Eyes. It is in process of being rolled out. So as David said, all health boards eventually will have access to this level of data. And in terms of obviously making improvements and having evidence-based decisions, clinical evidence-based for our improvements, it's incredibly powerful. So I'm going to invite all our speakers kind of to put their videos back on and start the Q&A. If you have any questions, we've got a couple so far, then do feel free at this point just to type them into the Q&A box. But we'll start with one. This is from Christina McDivitt, and this is principally to you, Breda, to say thank you for a really interesting presentation. And Christina was wondering if you have nurses trained to review OCTs and make decisions regarding treatment with IVT. That's the first part of the question. So is that a yes or a no, Breda?
It's a yes. Do we just type in, just say yes?
Yeah, that's a yes. And
yeah.
And if you do, could you tell us more about the training pathway and like how you're training basically those nurses? What's the competency development? That'd be great.
Very good. So there's a very robust training and competency here. It's actually provided by the consultants. So that would really be a question for one of our consultant leads. But this is something that's evolved. I mean, I think there's been nurse reviewers and specialist optom reviewers within this service since about 2011, 2012, I want to say. So it's a well-established pathways, and I'd say there's nurse reviewers and optom reviewers all over Scotland. So it's not unique to Grampian at all. It's something that it's a very well-established workforce that have a lot of support from within their services. Yeah.
That's great, thank you. And another question, actually, just following off on that, really, Breda, that came in is how, just about injections. How many are you delivering in each session?
So over the years, what we realised is that to keep our staff healthy and well, so we kind of set a number of 15 per session per injector. That's the number we go for.
That's great. Thank you so much. So just probably a question, maybe just for all the group really. A question coming from Stephen. in NHS Tayside is, do you see injections going into the community going forward? So do you see, I'm not sure there whether that means community optometrists potentially giving the injections or some kind of injection local community clinics. Any thoughts on that about, I guess, different ways of allowing these injections to get delivered? I know, Breda, obviously in Grampian you have optometrists doing the injections in the hospital. Yeah, any thoughts? David, you've unmuted. Have you got a thought?
Yeah, no, I think definitely moving closer to the community. You know, places like York have opened up IVT or macular centres and shopping centres, so it's easily accessible for patients. But they've still kept it under the supervision of the hospital team. So I think it would still be under the hospital team, but you know, there is obviously good potential for using spaces near and sort of community, which is easier for patients to get to, especially when there's such a premium on space in the hospitals.
Great. And sort of the utilising of community optometrists within that, can you see a potential for that in any? I know, Caroline, you've unmuted as well.
Yeah, I mean, there were quite strict guidelines around the room that you deliver injections in. So that would be difficult to do in an optometry practice, as long as we have those guidelines from the Royal College of Ophthalmologists. I know they deliver them in offices in the US or around the world, but the UK has quite strict guidelines. So I can't see that happening unless that changes.
Okay, that's great. Thank you. Another question again for really the whole group. This is from Ross, who says, what are the main factors that allow the better performing health boards to achieve the audit outcomes for wet AMD? That's a big question.
That's quite an easy one to answer. It's resource from boards at board level and support at that level. I mean, in Glasgow, we've had very good cohesive team for many years. We've had good middle managers who have been very supportive of what we know is needed, but we just haven't had the support from the board.
Mm-hmm. That's great. Thanks, David. And Breda, I'll just come to you, obviously, as one of the top performing sort of, as you know, in terms of delivering in the right amount of time. Is there anything you would add to that in terms of the main factors allowing you to achieve the timeliness of getting the injections done?
Funding is really, really important. So yeah, it is you can do nothing without staff. So it is sometimes being creative about use of funding. But yes, I agree. Having the facilities, having the rooms is really important, and having the staff to deliver the injections. I think clinical staff know their pathways. They actually know what they want to deliver. So it's been by, yeah, it's very hard to actually do it without staffing resources. So yeah, it's a constant struggle.
That's great. And like you said, I guess it's having the staff and it's the teamwork that goes behind that then, isn't it? And everybody. Yeah, that's great. Thank you so much. So a question here from Emily for Karen and Ash, asking, thank you. Have you switched all eligible patients to biosimilars, or are some still continuing on Eylea 2 milligrams? Did you meet any resistance from patients with regard to these changes?
So we switched everyone that was on 2 milligram Eylea to the biosimilar, and the plan is to switch anyone that's not extended to 12 weeks or beyond. So if anyone's on the biosimilar or 8 milligram Eylea, then they're at 12 weeks or more will be kept on that, and anyone less than that will be switched over. With regards to patient communication, that's an important one. So we sent out communication to patients saying that they would be switched over to the biosimilar. And in general, because we've had such a battle getting patients treated on time, when you actually get the opportunity to speak to the patient, say, by doing this, we can give you the drug at the correct and appropriate time, there's no resistance from patients because they know that then there's more chance of getting the treatment on time. So sometimes it does need more than a letter, and they do want that little bit of a conversation, but there's not been anyone that says, no, I don't want it.
That's great. Thanks, Ash. That's really helpful. If I just I've got a question here actually. And this is again probably for everybody. Is anyone aware? Are there recommendations or guidance on the number of injections that should be done in a session? Obviously, I know that Breda shared how many they're doing, but is there recommendations or guidance out there?
Helen, I don't think there is.
Okay.
The number is quite variable. I know that I knew that Breda's team did the 15. We tend to book 15 on a list because we do have DNAs and CNAs, so we're trying not to waste the slots. For a while, we used to do about 18 in Lothian, but for the reasons that Breda's articulated earlier, the injectors were kind of getting sort of sore hands and backs and things like that. So we reduced the numbers. Certainly spoken to my service manager colleague in Glasgow. I think they're doing slightly less, but they're looking to increase that. So I think about 14 or 15 is the average, but I don't think there's anything specifically written down.
That's great. Okay, thanks, Karen.
Getting it right first time says 16 in 4 hours.
How does that? I'll take that back to the team, Caroline.
But it is hard. You know, there's got to be, you need a very resilient workforce as well.
Yeah, that's great.
And you need to have some slack in that.
Great. Oh, thanks, Caroline, for that. Breda, a question for you again from Megan in NHS Greater Glasgow and Clyde. Is there any prior vetting of IVT sessions by clinical or nursing staff to avoid DNAs when patients are inpatient elsewhere, etc.? Those kind of circumstances.
Hello there. Yes, there's actually no specific ringing or phoning or checking the patients for if they're inpatients are. So what we do routinely is we vet to make sure that the intervals are correct. Because a lot of our patients have actually been switching to a biosimilar. So our nursing team, the specialist nurses, vet them and make sure that the prescription is actually written up. So there is vetting. We value pre-vetting our injection lists, but maybe not specifically for the DNA or CNA reasons, for other reasons. Yes, it is an important part of our day.
That is great. Thank you. And just one other question actually for you, Breda, was with regard to your 15 injections, is that every 4 hours? Is that in a 4-hour session? Is that the length of the session is the question?
It is, and I'd actually say keeping people well is very, very important. So yes, it's 15, but you know, a 16 person might be a little old lady in a wheelchair. You know, so there are, but overall, you know, our nursing team and our injectors, they all know that their welfare is very important to us, and keeping them well and not stretching people every session is important. So it's having their understanding as a team.
Great. Thanks, Breda. I'm going to make this question the final question, actually, just in terms of time, but I think it's a really important question, actually, for optometrist colleagues. The question is from Ross. Are optometrist referrals of good quality? And if not, or I guess those ones that probably are less good, what can be done or what can we do to improve them? For the floor. Caroline.
I would say yes, our referrals are very good quality. And if we haven't got what we need when they're sent in, then we'll go back to the optometrist, said, could you send the image? Could you send the OCT through the fovea or something like that? But yeah, because we're all working together to try and get that right, I would say that our referrals are good. But the communication between us is really important for that, to hear back what you didn't send and what we want next time, so that everyone's learning.
Yeah, that's great. David, I see you're unmuted. Did you have anything to add to that?
Yeah, I mean, imaging, as Caroline alluded to, is important. So if there is, in most optometry practices, we'll have imaging now. So just getting the imaging through is good. And communication both ways as well is really important.
That's great. Thanks, David. And Ash, Karen?
Yeah, I'll just say, as it's a bit hit and miss, we probably discharge about 50% of patients that get referred in. So it's reliant on, as I said, good imaging from optometry, but it's also reliant on good triage at our end, in that if we haven't got the appropriate imaging, we need to then write back to the optometrist. But sometimes, just with pressuring consultants, job plans, what have you, it's easy to say acute macular clinic, then to say please send the OCT through the fovea for this patient. So there's a few different issues there, and perhaps we can triage better, and perhaps we can get better quality images and things like that. But yeah.
That's great. Thanks, Ash. And it's probably worth saying on the back of all of that is that over the last year, we've been creating new, updated, should I say, Sky Gateway referral for wet AMD that actually many of the people on the call have been involved in. It will mean that things such as attaching your image of the macula will be mandatory, as that is one of the biggest things that came back as being, I guess, missing at times. And if you haven't attached it, it requires a mandatory explanation as to why. But also, hopefully, it's easier to fill in. And from the vetting side, we're hoping that the actual letter that has to be vetted by those vetting the referrals, it will be easier to digest as well. So we are trying to help make improvements. But I just wanted to just say a big thank you. So two things to say. I realise we're 1 minute over, so if you have got time to stay on for one more minute, there's just two things I wanted to say. The first was it's really helpful to understand what people have felt about our webinar today. We recognise that everyone's very busy, and giving up an hour of your time is very, very valuable. So it would really help if you have got, I think I can pretty much guarantee it will take you no more than 2 minutes, probably less. If you could quickly get your phone and just scan that QR code, it will take you directly to a little feedback questionnaire that will literally take hardly any time, but the information you give us is so incredibly valuable. It asks a little question in there as well about if you'd like to take part in something like this again, if there's any other type of service area you'd like to look at, that would be just helpful. So if I could ask everyone to potentially scan that and do that, certainly we'd be very grateful, and the speakers, it's really helpful as well. But to finish off, I just need to say a huge thank you, a massive thank you to everyone who's spoken today for the time they've put aside and the preparation, and just for such a comprehensive and interesting and helpful both presentations and discussion. Thank you so much for that. But also, as I say, thank you everybody who's spent an hour of their working day today to come and to listen and take part in this webinar. It is truly, as we said at the beginning, like Breda said, it's a team effort, and we have representatives on this call from both community optometry and the hospital, all areas. And that's the way ultimately that we are going to help improve services, is working together. So thank you so much. Really value everybody's time. And again, another thank you to our speakers, and hopefully look forward to seeing you again at another webinar. All the best. Bye for now. Have a great afternoon.